Hey everyone, and welcome. Today, we're going to dive into some really critical systems, the ones used in care facilities to monitor a resident's well-being. We'll look at how they build these proactive treatment plans right from day one, and maybe more importantly, what happens when an incident puts those systems to the test.
So, this is really the core question, isn't it? In an environment where the stakes are this high, you have to know the exact line between a small stumble and a serious event that has to be reported. And this isn't just about avoiding fines or paperwork, it's about making sure the right level of care gets triggered at exactly the right time.
So, where does it all start? Well, any really solid monitoring system begins the second a resident walks through the door. It all comes down to building a strong foundation with a really comprehensive initial assessment. And at the heart of this whole process is what's called the Individualized Treatment Plan, or the ITP. Now, the most important word here is living. Seriously, this is not some static file that gets created and then shoved in a drawer. Think of it as a dynamic roadmap for a resident's care, one that's designed to change and adapt as they do.
Okay, so those first 2 weeks are absolutely crucial. It all kicks off with a deep dive clinical evaluation from a licensed practitioner of the healing arts, that's the LPHA. But it doesn't stop there. Within 14 days, a psychiatrist comes in, reviews that assessment, and does their own independent exam. This two-step process is basically a fail-safe, It's designed to make sure the diagnosis is spot on and that the entire treatment plan is built on solid ground.
But once that initial plan is set, the work is really just getting started. So, how do you keep this plan alive and relevant? Well, it's all about constant, ongoing monitoring. This cycle is basically the engine of proactive care. The nursing staff are on the front lines, right? They're constantly watching and documenting any changes and progress notes. Now, if they spot a significant change, that immediately triggers a formal reassessment, and that new information feeds directly back into updating the ITP. This is so much more than paperwork. It's an active feedback loop designed to catch potential problems and adjust the care plan before a resident's condition gets worse. And what's really smart is how this whole monitoring cycle is tailored to what the resident actually needs. I mean, look at this. For someone in a crisis stabilization unit where things can change super fast, that plan is getting reviewed every single week. But for residents in a more stable recovery unit, a quarterly review is enough. The system is designed to adapt its intensity to match the level of clinical risk. But what about when a resident presents a higher risk right from the get-go? Well, the system has to be able to shift into a higher gear. And that's exactly where heightened protocols for high-risk residents come into play. So for residents who are designated as identified offenders, the standard procedures just aren't enough. Their ITP is actually developed in direct consultation with law enforcement, and it has to legally include the formal report from the state police. This could mean things like placement in a private room for safety, and this is huge. Any incident involving that resident triggers an immediate reevaluation of their entire treatment plan. At the end of the day, the buck stops with the facility to keep everyone safe.
Okay, let's pivot for a minute. We've talked a lot about proactive planning, but what happens when things actually go wrong? This is where we shift from monitoring to responding, and everything, I mean everything, hinges on having a clear, legally defined line for what counts as a serious incident. And here's that formal definition. A serious injury isn't just a little bump or a bruise. We're talking about an event with potentially severe consequences, something that could lead to a permanent disability or require surgery to fix. It's a deliberately high bar, and it's there to separate the everyday slips from the real emergencies that have to be reported to the authorities. This is where that formal definition gets turned into a super simple, practical tool. They call it the Band-Aid test. In a stressful situation, it just cuts right through all the confusion. Can you handle the injury with a simple Band-Aid? If the answer is yes, it's probably not reportable. But if you're dealing with broken bones or bleeding that needs more than basic first aid, you've crossed that threshold. It absolutely has to be reported.
This is a super common point of confusion. A resident gets sent to the emergency room. So does that automatically mean it's a reportable incident? The answer, and this might surprise you, is no. It all depends on what actually happens once they get to the hospital.
This slide really clarifies that crucial difference. If a resident goes to the ER just to get checked out for an evaluation and they're found to have no injury, it is not a reportable event. But the moment that visit results in treatment, we're talking stitches, a cast, surgery, anything like that, it immediately becomes a serious incident that has to be reported. The key takeaway here is so simple. It's the treatment, not the trip, that matters. So beyond just physical injuries, the regulations give us a very clear checklist of other events that are automatically considered serious. For these, there's no gray area, no judgment call. They are mandatory reporting situations. And the whole point of a list like this is to remove any and all ambiguity. Any death, any kind of assault, a significant medication error, any hospitalization at all, a person going missing for more than 24 hours, any criminal activity, or a fire, all of these are automatic triggers. They have to be reported, period.
And that really brings us to our final thought for today. As we've seen, these systems are complex, right? They have all these layers of proactive planning and reactive reporting. So the ultimate question for any facility isn't just, are we following the rules? It's, are these rules actually making us better? Are these protocols just a checklist for compliance, or are they a living framework that's actively being used to drive better, safer, and more responsive care for every single person?